Thank you very much, Amanda and Lavinia. Thank you to the CGC for the opportunity to share our work. And I also want to thank all my collaborators who are listed on this slide who work with me on this project. So I will be talking today about using gene expression profile-based classification of pediatric BLL in the clinical setting. So we know that BLL is the most common pediatric malignancy, that genetic abnormalities have a very important role in risk stratification and choosing optimal treatment. And we also know that the high quality and comprehensive genetic characterization is very challenging for pediatric BLL. Reason being, among other things, that this is a very heterogeneous disease with more than 20 different genetic subtypes being known today, and hundreds of different genetic drivers, including fusions, copy number variants, and sequence variants being responsible for pathogenesis of BLL. So at CHLA, to address this issue and provide as comprehensive genetic characterization as possible for our BLL cases, we have been using for many years a combination of different assays, including conventional karyotyping in FISH, chromosomal microarrays, and our custom next-generation sequencing panel that we call OncoKits. So for every case of diagnosis, we use combination of all these assays, which, as you can imagine, is pretty resource intensive. And still, when we analyze our diagnostic yield, we consistently have at least 15% of the cases that stay unclassified and no primary driver gets identified. So of course, we are thinking about ways to improve on this. And when the new assay, RNA sequencing-based fusion detection, became available, we were excited to apply it to our BLL cases as well. So this was introduced in the lab in March of 22. It's exome probe enrichment-based library preparation, followed by sequencing on Illumina instrument. And then we use our custom pipeline that combines 4 different fusion callers to call oncogenic fusions. And we use this for all our pediatric cancer-negative cases after our primary testing as a reflex test. So we obviously applied it to our BLL cases as well. And we were excited to see what will that do to our diagnostic yield. Is it going to help us to close that gap of about 15% of unknown cases? However, it was a very disappointing result. In our first 30 unknown cases where we used a fusion assay, we detected only 4 oncogenic fusions that are primary drivers and defined as subtype. There were 4 more cases that had potentially fusions of potential significance or VUS fusions, and then majority of the cases remained negative, 22 out of 30. So that made us realize that what we are missing currently in our BLL testing are not oncogenic fusions, are not the cases that have specific defined drivers. We are mostly missing cases that don't even at this time have known specific drivers that define those subtypes. Those are subtypes that are at present only defined based on the expression profile. And there are quite a few of those in pediatric BLL, including PAX5-ALT and ETV6-RUNX1-like and KMT2A-like and some others. And there are also subtypes that have specific drivers known, but those drivers are very difficult to detect with our typical assays. So those would include EPAR rearrangement with IGH or DUX4 rearrangement with IGH. For those, expression profiles still is probably the best marker to identify them reliably. So we thought, since we are doing RNA sequencing, maybe we should look at expression profile and see if we can use that diagnostically as a classification approach. We first did feasibility study on our retrospective cases, and this has been published, so just briefly, in this study, we showed full concordance between our classification based on our standard of care testing and classification based on expression profile. That was on 28 known cases. And then we got significant increase in diagnostic yield on our retrospective unknown cases. So this encouraged us to move this into clinical validation, and I want to talk for the rest of the talk, want to tell about our validation and implementing and how we plan to implement this clinically. So we first wanted to decide what will be our clinical approach for using expression classification. The scheme is summarizing the approach that we decided on, but the most important point is that there are multiple open source tools that were developed specifically for expression-based classification in pediatric BLL. And instead of choosing one of those, we decided to combine 3 best established with best performance, which are all sorts, all catcher, and MD-ALL. And then we take class, a determination, and a confidence score from each of these tools. We apply our own rules how to combine those outputs and then provide final classification. So this is just how we decided to combine outputs from individual tools. For example, we will classify something with high confidence if all 3 tools give the same prediction. All 3 have confidence score above 0.4, and at least one has confidence above 0.8. Then we defined our rules for low confidence classification, and finally, if none of the rules are met, then we call the case unclassified. And this is made to be very stringent on purpose because we want it to be as specific as possible, even if we sacrifice some sensitivity, but we want to be as confident as possible for clinical purposes in classification. So the next step was to test concordance with our clinical classifications. So far, we have tested 70 cases belonging to a large variety of different subtypes. And out of those 70, majority, 84%, classified accurately and with high confidence. Additional 12% classified with low confidence, and only 3 remained unclassified. So we thought that that was a pretty good performance. And then we looked in detail to unclassified and low confidence classified cases. It turned out that one unclassified case had low blast percentage, and then the others that were either non-classified or had low confidence belonged to those subtypes that are known from before to have non-distinct expression profile. And so that includes IM21 or near haploid cases. Those are known to have expression profile that is a little difficult to distinguish from other subtypes. So expression profile is maybe not the best approach for those specific subtypes, but they're easily detectable by our standard of care testing. We also looked at specificity by testing non-BLL leukemia cases, and we were glad to see that none of them classified when we apply our rule, except for one case of AML that was positive for KMT2A fusion that did get classified as KMT2A subtype, and however with low confidence. And then it is reasonable to assume that if you have KMT2A fusion-driven leukemia, that there will be expression similarities between KMT2A fusion AML and KMT2A fusion ALL. But that just reinforced our decision to use this only for confirmed BLL cases by pathology. And this is not meant to be used on any other disease type. We have also done limit of detection studies showing that this works down to approximately 28% blast, and we showed very good reproducibility from run to run. So it meets the criteria to be robust, in our hands so far, to be a robust clinical assay. So to close, one more thing that we did is, although validation is still ongoing, we wanted to see how well this performed on our prospective cases and how likely it will be to help us with our diagnostic yield. So those same 30 unknown cases, which we analyzed for diagnostic yield when we do fusion assay, when we now add expression-based classification, we increased our diagnostic yield from only 4 cases to 19 and from 13% to 63, and listed are the subtypes that were determined based on our expression profile classification. So we think that this will be increasing our diagnostic yield and will be useful, particularly for the cases, for the subtypes that need expression-based classification, like ETV6 trans1-like, and some others that you see on the slide. And then unexpected utility of this approach were cases that have more than one driver, and those are considered primary. So if we have 2 abnormalities that are known to be primary drivers in BLL, it becomes unclear which subtype this belongs to and which one is really primary and which one is secondary. So for example, we had hyperdiploid case with CRLF2 fusion, hyperdiploid case with eccentric 920, with BCR-ABL fusion. And so we were really interested to see what will these end up being based on their expression profile. And I will show one of those cases in our case studies. So to close, I wanted to show some case examples where I think this expression-based classification showed its utility. So this first case was standard risk BLL in an 8-year-old that relapsed soon after completion of treatment. And all our standard of care testing was non-informative. CMA did show multiple small focal deletions and then a larger deletion in the P arm of chromosome 12. When we did our RNA-seq fusion assay, it detected 2 fusions, one with ETV6 and other with Icarus. And so neither of these are known recurrent fusions, and so we still didn't know what the subtype was here or how to interpret significance of these 2 fusions. So when we looked at expression profile for this case, it classified together with ETV6 RUNX1 reference cases, but it does not have ETV6 RUNX1 fusion, so that puts it into ETV6 RUNX1-like category. And then when we compared the characteristics of this case with what is known at this point about ETV6 RUNX1-like cases, it's known that they have expression profiles same as ETV6 RUNX1, but without the fusion. But they often have concurrent ETV6 and Icarus abnormalities, and we did see ETV6 and Icarus fusion. And then, unfortunately, prognosis is not as favorable as ETV6 RUNX1 positive, which probably explains why the patient experienced relapse. And then the second quick case is one of those cases with 2 abnormalities that are known to act as primary drivers. And so this was hyperdiploidy with BCR-ABL translocation, with 922 translocation and BCR-ABL fusion. And BCR-ABL fusion was subclonal in this case, so we were pretty sure that this is actually hyperdiploidy with BCR-ABL as secondary. However, we thought this will be useful to check by expression profile, and it really did classify together with other hyperdiploid cases. So hyperdiploidy was the primary subtype for this case. So our validation is still ongoing, but we hope to launch this clinically sometime this fall. And we will implement it as a reflex test. So we will add it to unknown BLL cases for which we run RNA-seq for fusion detection. We will monitor performance over time and then maybe consider moving it more towards frontline testing because it's so comprehensive and it really does a great job in determining subtype for majority of the cases. So in conclusion, in our experience so far, when you combine expression profiling with calling genetic fusions, genetic drivers that can be called from RNA like fusions and some sequence mutations, this is a very comprehensive, precise assay for determination of genetic subtype in BLL. So with that, I want to thank you all for your attention, and I can take questions.